Good afternoon, and welcome to today's conversation about the coronavirus pandemic and ethical questions associated with many of the different healthcare conversations that are taking place. My name is Jeff Cohen, and I'm the Director of Public Affairs and Marketing at Informs. Informs is the largest professional association of operations research and analytics professionals. We have more than 12,500 members from across the United States and around the globe. And this is one of a series of webinars that we're putting together to share the interesting and important work that our members do in addressing some of the world's most pressing problems. I'm delighted that today we're joined by Dr. Julie Swann and Dr. Rachel Cummings to debate the different approaches to solving the coronavirus pandemic and the ethical dilemmas connected to each of those types of solutions. Dr. Swann is a department head in the Edward P. Fitts Department of Industrial and Systems Engineering at North Carolina State University. She is a research leader in using mathematical modeling to enable supply chain systems and healthcare to become more efficient, effective, and equitable. In 2009, she was on loan as a science advisor for the H1N1 pandemic and response at the Centers for Disease Control and Prevention. And recently, she has spent a fair amount of her time working with us at Informs, talking with media and others as an expert in pandemics, resource allocation, vaccines, and more. Dr. Cummings is an assistant professor at the H. Milton Stewart School of Industrial and Systems Engineering at Georgia Tech. Her research lies primarily in data privacy. Dr. Cummings has focused on problems such as strategic aspects of data generation, incentivizing truthful reporting of data, privacy-preserving algorithm design, and the impacts of privacy policy in human decision-making. Julie and Rachel, thank you both for joining us today. And with that, Julie, why don't I kick it off to you to start our conversation?
Great, thank you very much. Thanks for inviting me to talk a little bit about COVID and healthcare data and privacy. So, as an industrial and systems engineer, I've spent a good part of my professional life thinking about systems. And a lot of the work I've done is in healthcare, including pandemic modeling, as well as looking at data from healthcare records and claims records to do predictions in the health system. And so towards that, I do some thinking about healthcare data and some of the things that go along with it. So I brought some notes to set the framework for some of the different types of data and some of the different points that can come up with some of these different types of data. So when we think about data for COVID-19, we certainly should be thinking about things like the cases and the confirmed tests, the hospitalizations and deaths. That's part of the surveillance system. But then we've also seen in some cases there have been new technologies that have enabled location tracking and sharing of contacts and things like this to help with the contact tracing side of a public health response. Then you've got the disease itself, and with that, the biometric kind of data, so the genomic analysis on the disease itself, but then other kinds of things that might relate to what's going on in people's bodies and what different body types and how they're responding differently to COVID-19. Then there's a third category of data that I also think about, and that's at the systems level. And this is things like the allocation of critical resources. During H1N1, that was the vaccine that was being allocated by the federal government out to the states and then shipped out to local providers. And you want to know something about the type of allocation that's done, what approach is being used, who's getting what, when are they getting it, those kinds of things. And then there's also even medical product supply chains, where right now a lot of that data resides in the companies themselves. But we have learned through this experience and others that sometimes we're relying on a very small supply of a critical item that can really hold things up, like in the case of the tests for COVID-19. And this data appears in a variety of different places. So some of it is from health providers and labs and the electronic health records or claims data. Sometimes it's reported to, in the case of surveillance, reported to the state or federal government agencies. So you've got those playing a role in the data. You've got researchers who are both collecting data and using data. Companies are generating their own data as well. And then there's also data in other countries. So one of the key questions that I ask when I'm thinking about data is, can this data tell us something about where we are right now? And also, can it tell us something about what we need to do to improve our system? So here are a couple of example questions that data might be helpful in answering and determining what to do. So we know, for example, that communities of color have a much higher burden of COVID-19 disease and mortality. Why is this occurring is a critical question there. And in the early days of COVID-19, it wasn't fully understood even what this higher burden was. And so data is really important towards addressing that topic. Another one that I've seen recently, we've seen that the median age of people acquiring COVID has been dropping, especially in states like Florida. So as a researcher, I want to know, what does this mean for herd immunity in populations of young adults? This is particularly important given that universities will be starting up soon. A third example of a type of use of data is on the operational side. So we use data for contact tracing, but we also can use data for things like treatments, the convalescent plasma. For that particular treatment, you have to collect the plasma from someone who's already had the disease, and then it's distributed. And there are a number of things that go into that system, both on the data side and on the allocation side, that are pretty important. So overall, as a researcher, as a decision maker in general, I have the belief that if we can provide more data to the public, more data to media, more data to researchers, more data to government agencies, then we can make more effective decisions that can protect lives and lead to equitable outcomes in the population. So here are some different examples where data has come up in the news recently. So there's been a lot in the media about the hospital data that is now going to be reported, not through the CDC, but through a different avenue. We've got information on the racial inequities in coronavirus here in one news report. There's another news report that's talking about the distribution of a critical medical supply. And so, who is getting what is of real interest in that environment. Now, while we're talking about data, it's certainly critical to think about the ethics as well. And there are different levels of ethics that may come in that I think about sometimes in my work. So personal health information is protected by HIPAA. And then researchers also have various ethical guidelines that must be considered in their work, both in protecting data and in thinking about other things like informed consent. We also want to think that our government is being a good steward of the money that's provided by taxpayers. And so data can help point to good uses or areas for improvement. And then fourth on the list, I have public health, which, we think of it as protecting that overall population. So thinking about fairness and transparency in allocations of critical resources are something that I spend some of my time thinking about. Finally, on the list, I put the quotation that we think about in healthcare that says that healthcare does no harm, to do no harm. This is not fully true, actually. If someone receives a treatment for cancer, like chemotherapy, that chemotherapy treatment is doing harm to their body, but it's in the search for the broader good in that case. And just the same is true if you get certain kinds of screenings. Getting the screening, the radiology, can do harm to your body, but it's put in the context of the greater benefit that could result if you identify a cancer early and are able to treat that. So we have to think very carefully in healthcare. There are a lot of areas where, there are different alternatives and different trade-offs to think about.
Rachel, why don't I turn to you now? I'd like to hear your thoughts, and we'll go into some Q&A after that.
Sure, thank you. Thank you, and I'm very happy being here talking about these important concerns as we enter into now privacy considerations in the COVID-19 era, how we're facing decisions in terms of how to use and manage and collect data in ways that can have very important implications. In my work as a privacy researcher, I fundamentally think about privacy as being an economic decision, how you're trading your personal data in exchange for some goods or some services. And in the days before COVID, And that usually meant things like email, browsing, talking to your friends online. And it's a lot of us are beginning to learn maybe we're not getting such a great deal there. And we have to kind of think about if the things that we receive in exchange for our data truly do merit all the value of our data and of our privacy. But now in the current era, we're not talking about trading personal data to save lives. And so this is a much more compelling reason might be like very much worth it to kind of share data. And I know these are like a lot of the points Julie touched on in like her slides. But I do think the wrong perspective of this is to ask how much privacy should we exchange in terms of our lives, and thinking of this kind of as a zero-sum game. I think that's the wrong approach. And I actually think the right approach is to think about how can we have better technologies and better policies that allow both. Can we still have privacy while still enabling all these important applications based upon our data? And so I'm going to talk today about these potential approaches and when you might want to use certain tools and when they are not particularly applicable. And like the first answer that I always get is, why can't we just anonymize data, right? It works all the time, it should be fine. No, it does not work. And in the privacy space, everyone has their favorite tale of like a privacy gone wrong. My personal favorite is this story back from 2006. AOL published a bunch of their like anonymized records of their past searches, and they were trying to do this in service of the research community, and they were trying to do a good thing, and they took everyone's like personal information and they replaced it with a random number. And so this is a tale of a person numbered 4417749. But her search history contained things like contained searches for like services in her neighborhood, people who have her same last name, and then also homes sold in a very specific region. And she also searched for some potentially more embarrassing things, like some health conditions, elderly dating sites, and for a dog that pees on things. And so I bet she did not feel that her privacy was like protected, as some New York Times reporters were able to go through her search history, figure out who she was, and they even came to her house for a visit. And so this is her and that dog. And so of course this story seems kind of abstract, but as we move into contact tracing, we're seeing a lot of our remnants of our personal lives are going to be contained in our data. And we see this happening in some places where the contact tracing information is made public. And this is a story about a patient 31 of South Korea who visited a whole bunch of places, including hospitals, including church, including a buffet lunch. And this person's trajectory over a couple of weeks were made public, including where and when she was. And so if we think about where we all have been in the last couple of weeks, I bet we spend a lot of time in our houses, possibly in our office, possibly visiting friends, possibly at some more embarrassing locations. It's not enough to just kind of like anonymize our data. How we have to be thinking about more advanced tools that can still guarantee privacy, but can also allow all the value of the data. And so one tool that I use a lot in my work is that of differential privacy. And in the textbook about differential privacy, it says DP addresses the paradox of learning nothing about an individual while still learning useful information about a population. And this technology effectively works by just adding a small amount of noise some like calculations based on the data before they are shared publicly. And so there's some like pros and cons of this approach. In general, this works great if you're looking at like population level statistics. For example, think about maybe like CDC reports, local information about kind of like COVID hotspots in your area, even breaking things down into a kind of like finer grain, which places are wearing masks and which places aren't, things like this. And so this is great if you're looking at like a population level statistics, or if the exact number is off by some small amount, 1 or 2 people, it's fine, and we're still really understanding what's happening at the population level. However, this is not great if you're talking about doing individual data analysis and for things like contact tracing, because here, like at the individual level, having a difference between 0 or 1 infected people in close contact with you can make a tremendous difference. And so this is a tool if you want to do kind of like broader population level statistics, but it's not particularly effective for doing things at the individual level. On the other hand, we have a secure multi-party computation. And so this is a cryptographic primitive that allows many parties to jointly compute a function without sharing data directly. And they guarantee is that no one person is going to learn anything besides the output of the function. And so for this, think about asking, have I been in contact with a person who had a positive COVID test? And so think of this as the function we want to compute. And this is very nice because it removes the need for having some kind of centralized party, how we all share our data completely, and we send them perhaps our entire a trajectory of our day every day, and then kind of they decide and then communicate back to us if we have been in contact. And so that's a point of failure if we do have one single party who kind of holds everyone's data. And so this approach removes that need, and it allows communication between parties directly. And so this is great for communicating securely between a small number of parties. For example, 2 phones acknowledging if they're within 6 feet. If your phone sends a packet, and my phone sends a packet, and we can communicate. That's how this will work. On the other hand, this is not great for a large scale communication or for very complex algorithms that involve many people. And this is because this is a cryptographic approach, and that machinery is pretty heavy and pretty complicated, and it isn't really efficient to use at a large scale. It's great for talking between a couple people. It's not great for talking across the entire population. And so this would not be great for things like finding hotspots, or for looking at population level statistics. And so these are two tools that I think are very commonly talked about in the context of COVID privacy. MPC is currently being used in a few of the tools that have been deployed in terms of contact tracing, and so this is a great tool. But I think that beyond these two tools, we also have to think about the policies and the data governance. And so as we talk about contact tracing, in terms of sharing personal data about individuals, about their daily life, about things that they may not want to be made public, I think this raises a whole lot of questions. And this is things about the data collection and who owns it, and data ownership. Where is it stored? Is it stored in a centralized authority, or is it happening locally on device? Also questions about downstream data use. Can the data collected for this purpose be used later? For example, can it be communicated to a person's insurance company? Under what conditions, what timeline is the data going to be deleted? Also, in terms of like convincing users to like participate in these services, are they going to be opt-in, or like are they going to be opt-out? And we know in general that we have much better participation in services that are like opt-out than opt-in, but it's unclear if we can really gain informed consent, or are people just too lazy to really opt out? Also, I think in a lot of these cases, have a lack of a perfect signal. How do we feel about the appropriate error in these cases? And in general, it's probably much better to have a false positive than a false negative, because that means we're being kind of like overly cautious and like containing the spread. But of course, we can't have too many false positives, otherwise it'll become overloaded. And then in general, as we share information, as we tell people you have been in contact with a person who has been infected, what does that reveal about the sick person? How about the like of healthy people? Is there a particular adversarial model that we're assuming, and do we think that adversarial model actually matches practice, and kind of like, are we really thinking about all possible bad things that may happen? And so really, I very strongly believe that we should be using data in the fight against COVID. We have to make sure that we're using technologies wisely and that we are thinking about the policies surrounding data. And I want to end by saying privacy guarantees are critical in the fight against COVID. And like privacy doesn't happen like in a vacuum. Data collection doesn't happen in a vacuum. And because sharing data in these cases are voluntary, and because people can lie if they feel uncomfortable sharing data, that we really have to incentivize people to provide data. And I think in this case, it's a very compelling reason you can save lives if you share data, and that itself really should be a good incentive. But of course there are like many other concerns happening in the world at the same time, and we've even seen that in some places coronavirus intersected with other global problems, including racial inequity, and the protests happening around that are really intersecting COVID. And we can't assume people are going to be comfortable sharing their data if we don't give them satisfactory privacy guarantees. And so I think that kind of like a lot of people may think privacy is a hindrance in terms of having high quality data, but I actually think privacy is essential, and privacy guarantees are going to like facilitate better, more effective data sharing.
Great. Thank you so much, Rachel. You know, you both have sort of painted a really interesting portrait for us. Let me start, Julie, something you've touched on in the press that I don't think you mentioned in your presentation, but I think is important in the context of this, is you've described developing a COVID army. Can you talk to us about what that is, what that means, and how does that square with some of the concerns that Rachel was just laying out in terms of securing people's privacy?
Great question, Jeff. Yes, in this piece that I wrote about creating an army of the recovered for COVID-19, it was a little bit ago, but basically I was volunteering to be inoculated or to receive exposure to COVID-19 with the goal of, if enough volunteers were available, then we could start providing some protection to those around us, to those who are most vulnerable for increased mortality or severe outcomes. Now, on the one hand, this may sound like a terrible idea, go out and, you know, and I'm not suggesting having a COVID party, right? I'm suggesting under the supervision of a doctor or scientist and, you know, systematically evaluating people for any potential comorbidities that could lead to increased risk, having volunteers with informed consent, you know, walking into it knowing, you know, to the extent possible, knowing the risks associated with this exposure to the disease. So with that systematic approach, you know, intentionally putting myself and the other volunteers at increased risk. So, you know, it goes back to that healthcare statement, do no harm. You might think this is a terrible idea. Now, of course, before we had a vaccine, that was essentially what we did with smallpox, is that we exposed people to low doses of the disease so that they would develop immunity. And so that it's basically an extension of that idea. And others have described it as well, both for before there's a vaccine, but even in the process of vaccine trials, where right now we're not intentionally giving anyone any exposure to COVID. And as a result, those vaccine trials take longer, they take more people. And so, you know, that's a challenge. So going back, you know, it's the idea of, could we have some sacrifice for a smaller number of people with, you know, potential benefit for more people in the community? Now, there can also be data, ethics around the data, but some of the ethics in this particular example are more around the actual harm and the risk for those individuals. If this army of the recovered was used to as a potential source for convalescent plasma, then, you know, there are some data issues that could come into this, but there certainly are a number of ethical issues associated with an activity like this that we as an American public and indeed around the world have not made a decision to move forward in that kind of way.
I found it interesting that you likened it to the treatment of smallpox before there was a vaccine. And I can't help but wonder the differences that however many decades it has been, you know, means in terms of how people perceive, you know, their role in society, how people think about their own privacy, you know, rights. And I know there's no answer to those questions, but it certainly does lead, I think, to a tie-in with something that Rachel mentioned in one of her last slides around data privacy. And that is, and whether it's the herd, you know, building up herd immunity or contact tracing, we're talking about a tremendous amount of new data being introduced into the world, right? Who owns it? How do you make sure that it doesn't fall into the proverbial wrong hands? If the technology companies are using phones to do this, who owns it? Who has the right to access it? What assurances does the public have that whatever the implications of that data set are protected for them? And so maybe Rachel, I could start with you, and Julie, you could weigh in on that.
Yeah, and I think that's a critically important question that unfortunately is kind of only being thought of as an after fact. And the truth is, this is being done very differently across different countries. In the US here, we have like the primary app was like a jointly designed between Apple and Google. And so these are like private companies sharing data. We do also have some like public government statistics through the CDC, although we are now seeing that data is being sent through a different route that is like currently unclear what's going to happen with it. And in other countries, there is much more like a government involvement in the data collection, as we're seeing in places like South Korea and in Israel. They both have amazing contact tracing apps, but they're run by the government. And so we're seeing very different data ownership structures happening happening kind of like across different countries, and it makes sense as we have different privacy expectations happening like across the globe. But I do think a lot of these questions are very open, and it's really unclear what is the answer, and especially in terms of like downstream uses, as we are like collecting all these enormous data sets, what's going to happen with them later? And it hasn't quite been clear. And I think this is also being illustrated now like as we're seeing in the US government data that was previously sent directly to the like CDC, that is, at least in my experience, hey, like a trusted government authority, it's impartial around it, and now that data are being sent elsewhere, and it's kind of up in the air. And I can certainly imagine for a lot of people who are like deciding if they want to share data or not, if they're deciding, if I go out, should I leave my phone at home so it can't be traced? All of these questions. I think the answer will really depend on what the kind of privacy guarantees are. And I can certainly imagine a lot of people will provide lower quality data in these ways if they're not given satisfactory privacy guarantees.
Julie, you want to add to that?
Those are great points. You know, I'll add a couple of things to it. For healthcare data, we do have laws that govern protected health information, you know, HIPAA, for example, and there's a list of things that unless those are removed, it is considered PHI and it is protected by law. But there are many other things that are not fully protected. So the mobility information, for example, that's gathered from cell phones and things like that. And, you know, that's currently residing in companies, but, you know, who knows exactly what might happen in the future. Even with the healthcare data, sometimes there are some issues around who owns it and who can use it and how can they use it. So for convalescent plasma, you need to find someone who has already had COVID and recovered from it and collect plasma from them. Well, how do you find them and who is collecting that? So typically the group collecting it, it might be the Red Cross or a blood collection agency, but they're not necessarily the ones who have the information on who has had COVID-19, which is coming through the health system and lab reports and things like that. So you have to find ways for these systems to interact in a way that does protect the health information by law as required, but still enables the collection of convalescent plasma for treatment as needed.
You know, it's been clear as this pandemic has progressed that people of color seem to be disproportionately affected you know, by the disease. And I'm wondering the impact of that phenomena on concerns around bias in the data. In my conversations when I'm on Capitol Hill, I hear frequently, and this is before the onset of COVID, that there were concerns with bias and fairness and equity in the data. I'd have to imagine that this exacerbates that concern. And I'm wondering if either of you are seeing or have any thoughts about how you ensure that that doesn't happen. Yeah.
That's a great question. And let me separate a little bit the different kinds of bias that could be at play here. One is the bias and the fairness and the privacy of the data itself. And a second is the bias and the fairness associated with any algorithms that might be using that data or other data. You know, in the early days of COVID-19, what we were seeing is there was not enough data available to really determine, you know, how much greater the burden might be on communities of color. And so that was a real challenge. And so how do you collect that data? In some of the ways that some of that data can be censored is if you don't have data collection points in the neighborhoods where people are, if you don't have testing in the neighborhoods where some of these infections are occurring. So that's one part of it. There are other kinds of missing data at play here. So with communities of color, we don't have a full understanding of why this is occurring. It could be related to essential worker status. It could be related to comorbidities like diabetes. It could be related to lower access to healthcare, or it could be related to other things. But we don't have a real sense of that right now. I was looking for data on essential workers the other day, and I had difficulty finding data on how many essential workers there were in different counties and what types they were. And that information can then help us determine how to address some of these issues around bias. And then that doesn't even get into the bias that might be there in the algorithms.
Rachel,
Yeah.
do you want to add anything to that?
Yeah. I think Julie made some great points. And one thing that I really want to emphasize is that we do have a lot of like confounders as we look at like communities of color, because we do know, as like Julie mentioned, people of color statistically tend to have lower access to like healthcare, and when they go in for like treatment, they tend to be not like believed as much, and there's actually data on this. And so if they say they're sick and it hurts, they're not believed. Additionally, we have a very disproportionate amount of our essential workers are like people of color. And we know, of course, all these are like very high risk factors in terms of COVID. And so I completely agree with like Julie's point, how we really don't know. Are we seeing people of color being infected at like higher rates because there fundamentally is a kind of like medical biological difference in the way that this like disease interacts with different communities? Or is it that these like communities are kind of already at a higher risk for things that are like totally separate from the like disease as a medical question? And it's really hard to like disentangle this because we only have the data that we have. And of course, in like a perfect environment, I would love to say, okay, and so let's like, compare the data of the white essential workers and the essential workers of color and kind of treat it like as an A/B test. But because we are in this like healthcare crisis, we can't do A/B tests, and we only know these individuals are sick and these are not, and then try and make inferences from that data.
Great. So let me ask you probably one last question here.
Sure.
And I'm not going to ask you to make any specific policy recommendations, but what do you think are the top couple of issues that policymakers really need to get their arms around in order to create some uniformity around the country for how we're tackling this, both from a healthcare perspective and a balanced privacy perspective? And Julie, I'll turn to you first.
Well, you give me the hard task, Jeff, to go first. There are several different things that I think policymakers should be thinking about. And I go back to, it depends on what kind of data we're talking about. So certainly there are challenges around protected health information and individual information at play in things like contact tracing and convalescent plasma and those kinds of things. What I think that we also need to be thinking about is data from a systems level. And right now, I have to say I am worried about, what are we going to do when we have a vaccine available and it's in short supply? Who's going to get it and for what reasons? And, that is just such a weighty question. There's a lot of different things on the ethics of that. But there's also things related to the transparency. How did we go about making those decisions, and what are the decisions that we made? And, I think that that's a really critical area over the next few months that we're going to need to sort out.
Right. Rachel, any thoughts?
Yeah, I actually think the main challenge is one that we haven't even talked about here today, which is that we need to like depoliticize the fight against COVID. And this is not a political issue, but this is a deadly virus causing a global pandemic. And this shouldn't be a partisan question. We should stay home if we can. We should provide healthcare to those who are sick, and we should all wear masks if we go out in public. And this isn't a political question. It is simply one of like healthcare and of wise behavior. And I think if we could like convince everyone of this, I think we would see a drop in the number of cases. But I also think that is only the starting point. So we're still trying to get this virus under control, and there's a lot more phases that come after this. And so as Juliet mentioned, vaccines, how are we going to allocate vaccines? So like a research question at this point, we don't really know how long immunity lasts, and there's kind of like a conflicting information. Is this vaccine going to be kind of like once in a life? Is it going to be once a month? Is it going to be annual? And we don't really know yet. And so that question creates all new kinds of like supply chain questions. Can we deliver appropriate number of the vaccines to the people who really need them the most, and also at the right intervals? And as like Julie mentioned, there is also a fairness question here. If we don't have enough vaccines, and of course at first we won't, eventually we will, but as the first batch comes, who gets them first and why? And I think this is a very sticky question, because we already know COVID is very interlaced with things like race and poverty levels, and it like doesn't look good if we make decisions in terms of who has like a life-saving virus based on things like race. We also can't make those decisions separately, because we know certain communities simply are going to be at a higher risk. And so I think all those policy questions surrounding allocation of scarce resources is going to be very important when the time comes. Hopefully soon we'll have a vaccine.
Great. Well, I think what the conversation has shown us is there's a tremendous amount to unpack here for the public and for policymakers. And there's no way in one conversation to really adequately address it all. But I'll close out, I think, going back to a point that Julie made in your presentation about the duty to do no harm. And you all have pointed out that that is at best an amorphous definition as we balance the different tensions and needs that we have as a society in combating this and protecting the security of the country. So with that, thank you both for your time, and look forward to continued conversations.
Thank you. Happy to be here.
Thanks.
Thank you.